focus on that, see a significant reduction in the amount of pills being dispensed. And the highlight in blue talks about for the first 6 months of 2014 as compared to the same time period in 2012, there's been a 50% decrease in the number of opioid pills that have been prescribed for pain. So some highlights there of a very successful pain management policy, working with the provider community and establishing criteria for prior authorization that has been beneficial both to the patients and understanding the care that's being delivered, and also to make sure that we have the appropriate clinical evidence that we're using to monitor prescriptions of pain.
And just add, this is an area where we received a lot of national interest. Dr. Flanagan, our medical director, has been asked to come and speak about how this has occurred, and you may recall Dr. Flanagan has presented to the legislature about his efforts to work with the various professional associations around the development and the buy-in to this pain management protocol so that it was more readily embraced and implemented, and its success has certainly gotten the attention nationally and certainly with other organizations in the state.
I would just ask you to flip to slide 40 and 41 to get a very quick perspective. We have a radiology management program also in the Office of Maine Care Services, and as slide 40 identifies, this really is focused on prior authorizations for CT and PET scans, and really what we're looking for here is clinical appropriateness and reduction of duplication of services, making sure that individuals need the radiology that they're receiving and that it already hasn't been done somewhere else, or it's not too close of a period of time to be done since the previous one has been done. And as you will see, we have seen some significant cost savings around the implementation of this, but really we're focused on the clinical appropriateness of it. And we want to make sure that when individuals are receiving these, that they're receiving these scans and for the appropriate purposes.
I'm going to go through these last few slides fairly quickly. You may want us to return to do a more in-depth discussion presentation around the state innovation model grant. This was an opportunity afforded to states through the Centers for Medicare and Medicaid Innovation. Maine was one of only 6 states to receive this grant. It's a 3-year grant designed, though, as a statewide effort to transform the healthcare delivery system. You can see certainly what the goals are for Maine's SIM grant: to reduce the total cost of care per member per year to the national average, to improve population health in at least 4 disease categories: diabetes, mental health, obesity, and tobacco, improve patient experience scores for targeted practices by 2% from the baseline, and increase the number of practices reporting patient experience from 50% to 80%. On page 43 is the timeline for this 3-year grant, just to give you a sense of where we've been with implementation. April 1st of 2013, with the grant concluding September 30th, 2016. If you move to page 44, this gives you a high-level overview of the domains within this SIM grant that we are focused on as they are across the page: strengthen primary care, integrate physical and behavioral health care, develop new workforce models, develop new payment models, centralize data and analysis, engage people and communities. And again, still really building upon what we've talked about, which is reducing avoidable, preventable expenditures in the healthcare system, supporting the transformation with payment reform that is rewarding these investments, rewarding quality and outcomes, real-time data and data analytics. And as I just want to emphasize again, this isn't just about Medicaid, this is across all payers. We have a broad engagement of stakeholders in our steering committee and in our subcommittees that report to the steering committee. The effort to provide good and meaningful data around which practices can act is challenging. We have really made great strides in utilizing Maine Health InfoNet in providing that real-time data and notification. So if someone has been discharged from the hospital, the primary care practice can get real-time notification to either follow up for an appointment or that transitional care from hospital to home. Similarly, if someone has been in an emergency department and if it's been for a non-emergent matter, that call within 24 hours can make a huge difference in changing their use of care and certainly encouraging them to use their primary care practice. So a lot of work underway. We've given you details in each of those pillars of some of the major areas of focus. As I've said, this has been an amazing undertaking. It was one of those where, as we realized once we received the grant, the magnitude of work and engagement, it certainly has been overwhelming, but the opportunity it presents for the state of Maine is great. So long as we can stay, as I like to say, laser beam focused on some tangible results that we can continue to advance, and really that real-time notification from relating to the ED or hospital discharge, admission and discharge is a great example of providing that tangible, immediate benefit to primary care and physicians, and continuing to move on to the next opportunity to make these investments in the transformation of the healthcare system. So certainly more to come on that, and happy to provide a more detailed presentation on the work, but that will go a long way to also helping and supporting Medicaid in its efforts.
And we have a question from Representative Brand.
Thank you, Mr. Chair. On the SIM grant, I can't remember how much the total was, and how have you, I'm a grant writer by profession, and I know sometimes when you do a grant budget, sometimes you're guessing, you're giving your best guess. How are you tracking with the cost of and the expenditures in the grant? I mean, are your guesses coming in close? How are you doing with that?
Yep, we can certainly get you more information on that. It was a $33 million grant over 3 years, which really, when you think about the work that is involved and the kinds of investments, and again, compare that to a $2.5 billion annual Medicaid program. We work very closely with key partners and stakeholders in designing the grant, although as with any grant, and you can appreciate this, the timeline was not all that helpful in having to develop and submit this based upon the initial deadline. But we can get you more detailed information on how that is tracked. I can tell you that one of my disappointments is that we didn't include more funding requests for data analytics within the Department of Health and Human Services, because that's a huge deficiency in our IT support.
I have another question. Thank you, and as a follow-up on the SIM grant, one of the goals is around tobacco use, and just curious as to how that plays in with our Healthy Maine partnerships and how those programs kind of build on each other or work together. And maybe that's something for a future, but I'm curious about that.
Well, I suspect we're going to be talking a lot about that related to our budget proposal to take funds out of the Fund for Healthy Maine, from the Healthy Maine partnerships to support primary care practices, and our support for the increased primary care physician reimbursement rate, and continued support for the health homes, given that those funds were temporary from the federal government. We believe that there's great opportunity to continue to expand on their results to support improved health outcomes and addressing tobacco utilization. So I'm going to...
One more from Representative Sanborn.
Yes, thank you. Thank you, Commissioner. And as you know, I've always been kind of in lockstep in regards to the idea of value-based purchasing, and really appreciate all the work that's being done with the SIM grant, and patient-centered homes and what have you. So all of that is great. I wasn't going to ask this question until we got more into the budget, but I know that you've talked a lot about prevention as you've gone through your presentation here. And I have a concern about realistic. I mean, I know that, you know, tobacco is our #1 killer, obesity is our #2 killer. You've mentioned, and the governor has both mentioned those as great concerns. But, you know, again, the budget seems to be eliminating the HMPs and all the money that is put into both tobacco cessation, work with obesity, work through the school health centers. So can you address how you're expecting that preventative work to be done when many of these things are being cut out of the budget in regards to prevention?
Yeah, so I would, I don't agree with the characterization that we're cutting prevention. I think the question is where do we, and we may disagree about where the opportunity is to conduct that prevention, early intervention. Our proposal is in support of primary care and those practices and the health homes and their work. The question that we need to evaluate is where is the best return on investment, what has contributed most to affecting tobacco utilization. We certainly are looking at research, the banning on smoking in public places, the tax on tobacco. Those have been significant contributors to the rate of tobacco use, and yet we still have a high rate of tobacco use within the Medicaid population. So as we look at our opportunity in Medicaid, what the intent was from the tobacco litigation, we want to invest in and support prevention and early intervention in the primary care practice. So we are interested in having a more robust discussion about where we can really see more tangible results to affect that tobacco utilization, and we are looking to the primary care practices.
So completely through primary care and not through any other kind of community prevention programs or in the schools?
Well, we're talking about the funds that are being proposed to move from the Fund for a Healthy Maine. There certainly are other grants, other federal grants. Certainly the federal CDC spends significant funds around public education, public health promotion. So we can provide perhaps a more detailed, comprehensive picture of the amount of funding and what this represents of that funding as it relates to public health and education.
So you want to move on into another question? Oh, I'm sorry, Representative Gibbons.
Thank you, Mr. Chair. I'm just hoping if maybe along those lines, maybe when you're thinking about this, if we could, sometime later in the process, get some information on sort of how you are assessing the effectiveness of safe prevention programs, various ones. Because if we are moving wholesale out of public health-based sort of programs like you find with Fund for Health Maine into the physician's offices, I'd just like to understand a little more about the efficacy of those two different models.
Happy to, and as members of the returning members of the Appropriations Committee may recall, we like to provide as detailed of fact sheets and background documents for each of our budget initiatives, and we are near finalizing each of those, and we'll try to incorporate that into the document and into the specifically into the budget initiative pertaining to the Fund for a Healthy Maine and the transfer into Medicaid. The additional transfer, of course, is already funds, significant funds that are transferred already out of the Fund for a Healthy Maine into the Medicaid program.
Thank you.
You're welcome.
Senator Cates is good.
So do. Thank you, Mr. Chairman. And I wanted to ask you a question about the Concord communities and the initiative to share savings. Someone's expressed to me that they didn't understand the economic model of how that works. In other words, if a hospital reduces its costs through good practices by, say, $200,000, and you're giving them back $100,000 because you're sharing those savings, the hospital is still losing $100,000. So where is the economic, I understand that the hospitals are trying to be good citizens, they want to bring down the cost of healthcare and all that, but they still have to worry about their own budget. But how does that work economically for the hospitals to, instead of losing 100 cents on the dollar, you're now losing 50 cents on the dollar?
You want to talk about the actuarial approach?
Sure.
there was an extensive, and I mentioned when I was talking earlier about the total cost of care for the members, the attributed members for the lead entities, and there was an extensive actuarial analysis done, compiled, that identified those total cost of care. There were optional services that were included, there were mandatory service populations that were included in that total cost of care calculation. You are right, though, they have to achieve savings, and that means that at the bottom line, somebody's revenue has changed. The other side of that, though, is if there's inappropriate utilization of the emergency department, inappropriate for readmissions into an inpatient stay, again, we're trying to take the focus away from and really manage that, but focus on integration into the primary care. So overall, there has been a savings achieved, and you're right, they could share up to 50% of that savings. At the end of the day, there is a reduction in revenue. There is a reduction of that $200,000 in that example, and they are able to share in a portion of those savings. But again, it's making sure that the individuals are getting the care in the right system, not just through the emergency department, which is a higher cost center.
Are you chomping at the bit?
Yeah,
Go ahead.
yeah, it seems to me that a big piece that's missing out of your presentation is what we're doing with the people that are at less than 138% of the federal poverty level. We know that those folks exist, that they're still using the ERs, that they don't have access to a primary care physician, they don't have access to any care, period, other than acute care, which is, emergency room care that is very inefficient. So I'm wondering what your and the governor's plan is to take care of those folks.
Well, that's a big question. I'm not sure that it's a big missing part of our presentation, since our purpose today was to provide background on the existing programs and services within the Department of Health and Human Services and within the Medicaid program. As you mentioned, there clearly are a number of changes that have occurred as we've tried to get away from the crisis-oriented management of a Medicaid program that has reeled from one shortfall to the next, leaving many people who have Medicaid without a robust array of services, and certainly not those that are so critical to their health and well-being. Difficult decisions, difficult debates here in the legislature about those decisions. There are many individuals, as you mentioned, who within that federal poverty level who are eligible under the Affordable Care Act for significant subsidies under the exchange. We'd be happy to do a presentation as it relates to that framework. There is a larger issue that is a federal issue about the Affordable Care Act post the Supreme Court decision. The Affordable Care Act presumed mandatory Medicaid expansion and did not allow for subsidies for individuals under 100% of the federal poverty level. When the Supreme Court struck down the mandatory nature of the Medicaid expansion, the Congress did not go back and address the issue of individuals under 100% of federal poverty and their access to subsidies. Of course, for those individuals who also have a federally qualified health center near them, federally qualified health centers are mandated to provide free care for anyone 100% or under of the federal poverty level. You ask what our perspective is, what the governor's perspective is. Certainly our goal is to improve Maine's economy, to provide more employers and more jobs with good paying salaries and benefits as one of the best ways to help support people with access to improved coverage. But happy to come back and talk about other areas related to the Affordable Care Act and the connectivity with the federal exchange.
So at that point, if you'd like to get into the numbers and we'll deal with budget initiatives, let's do a change of pace. I don't really want to get into a deep policy discussion on this.
So one of the additional packets that we've provided that was behind your PowerPoint in your blue packet, just because I'm sure you don't want me to go line by line, but I thought it would be helpful for you to have the historical spend for each fiscal year broken down by each program area. It looks like this packet, it says at the top, Department of Health and Human Services, I've got to get better glasses. Expenditures for state fiscal year 2009 through state fiscal year 2014. Very detailed on the expenditures by fund for each of the program areas. So again, don't need to go through that, but I thought would be helpful for everyone to have. And if, as you do review, if there are questions, happy to come back and revisit that.
You have a question? Yeah, Representative Martin.
I have a question. I very quickly looked at this. I see, could you explain the Office of Commissioner?
Well, that's my office. Within the Office of Commissioner includes the contract management, division of audit.
Is that why there's a bump from 21 million to 25 million?
What are we just?
I'm looking at the second page. In the first line, if you look at the bottom, 43 million to 48 million.
Yeah, let me see, on the state fiscal year 16 and 17, this includes our budget initiatives, I believe. So this would be, no, it's the legislative approved, I'm sorry, I thought we had taken these off. So this includes the baseline budget, and I'll have to take a look,
Okay.
Representative, because part of the challenge whenever we put the budgeted amount.
I know everything dumps together.
Well, it's the over-allocated funds
Right.
that can distort. When you look at the expenditures have been fairly consistent, but let me take a look and see what
Yeah,
may be.
caught my eye, because it's really the only one like that in the,
Yep,
those
yep.
3 pages.
Let me take a look and see
Thank
what the. So now turning to the right side of your packet, you'll see, again, just trying to provide you with, building on the Medicaid information that I shared and the rate of increase, you'll see for, we provided actual expenditures at the top part of the document for the Medicaid program, beginning with state fiscal year 2012. For fiscal year 2014, there was a reduction of 0.8%.
Commissioner, where are we?
I'm sorry. So on the blue packet on the right, under the tab
Yeah.
labeled historical projected, you see this document?
Thank you.
Everybody got it?
Yeah.
So this was just trying to provide you with some overall total spend, total dollars by fund, and the percentage change year over year. The top half is Medicaid specific. The bottom half is the overall department for state fiscal year 15, 16, and 17. And Alec, you're going to correct me, but these include our budget initiatives. You want to?
Yes, we do, Commissioner.
So-
All the numbers you're seeing on the right are net of our budget initiatives, both for the Medicaid program and all DHHS.
And we put that in there just, again, for our own purposes as we're looking at our budget that we are proposing to the legislature, what the impact would be for the overall year-over-year expenditures. If you turn now to the tab, the Maine Care Object Code, this is typically a document that the Appropriations Committee has had a lot of interest in evaluating within each of the service lines or the object codes as they are identified in the Maine Care program, what the spend has been. And the last two columns or the last three are based on our forecasting model, which I'm going to have Alec spend a little time. In fact, we may jump over the next two tabs and come back, because I'd like Alec to provide you with just a little bit of overview of our Maine Care forecasting tool. But again, this is just intended to provide information about where the spend is and what the percentage impact has been, looking first at all funds, total spending in Medicaid, and then on the second page, looking at the state dollars within the Medicaid program, providing that breakdown by service area. If you would just move now to the tab, and we'll come back to the budget initiatives, I promise. If you would just go to the Maine Care forecast summary, I wanted, Alan, this is some work that we've had underway for the last couple of years that for members of the Appropriations Committee and members of the Health and Human Services Committee who have had the chance to spend some time talking about this with us. This has been such a critical investment to move away from more of a rear view mirror analysis of what we spend and projecting forward to a much more sophisticated analysis of trends, seasonal trends in the various service lines to try and project out what the anticipated expenditures are in the Medicaid program to both inform our management of the program day to day, but also to inform the budget submission and your consideration of that. So Alan, if you would mind walking through that?
Yeah, I'd be happy to, Commissioner. So, looking at the document, I won't take you through it line by line, but I do want to just give a little bit of background of the forecast that we use. It's something that the department has put a lot of effort into. We're really excited about the results. We're running a forecast right now. We run that every 6 months. We expect results late next week. So it's a great process to watch. We use something called the Holt-Winters model. And if you see at the top, second subject after background, Holt-Winters triple exponential smoothing. It's obviously a bit of a mouthful. What that means is just like any algorithm, Holt-Winters uses exponential smoothing to take past data, smooth it out, project it going forward. Triple exponential smoothing means that we're looking not only at that past data, but also a trend in seasonality in the future. Yep.
Sorry, we are under the Maine Care forecast summary tab for those of you who,
Oh, thank you.
sorry.
No problem at all. Does everyone know what document I'm looking at? No need to make triple exponential smoothing any more confusing than it might sound. So, stepping back, triple exponential smoothing. Very simply, we're looking at past data, we're looking at trend, we're looking at seasonality. Holt-Winters method takes that, produces projected future outcomes for us. Then we bring together our main care forecast team. They come from across our department, review all of that data together. What they're doing at that point is looking for anomalies in the data and also considering what that algorithm would pick up. So changes in the law that we already have, recent acts by the legislature would be a very good example. Rule, both state and federal, another example. Those are things that our experts come together from across our department. When you think about that group, it's our Maine Care Financial Analysis Group, Maine Care Data Analytics Group, other professionals from licensing, eligibility, rate setting, from our audit division, and also from the department's DAF's Financial Services Center. So it's a large group of individuals, a talented group, various sets of expertise coming together to socialize this forecast, discuss what they're seeing. Do these results make a difference? Do they make sense to us? Rather, we forecast at 75 different object codes. So we're running the forecast for the top 75 cost drivers for the Medicaid program. We forecast each of those, roll them up into the overall projection for Maine Care. Once we've socialized that, once we've discussed each of those projections, looked at the overall roll-up, then finally we assign funds to the account strings, the various cost drivers of the program again, and we then separate them through our funds, whether it be general fund, federal fund, special revenue. So that's a bit of an overview of what we're doing with the forecast. As I said, we're running our latest forecast right now, and we're more than happy to discuss the forecast in additional detail if you're interested in hearing about it.
Look at the questions. You just want to say triple.
We'll just refer to it as the triple X, is that what you're suggesting?
No, I don't think we should.
Okay.
We probably should.
Yeah. So I tend to be curious about things that I don't understand at all. But I remember two years ago during the legislature, we also talked, I think you were just beginning to, the department was beginning to use this model. model, and implement this model. So I guess one of the things I'd be interested in knowing is, you know, you've got some history now, you know, similar to other revenue projections the state does or businesses do. You know, what does the history at this point tell us with respect to the accuracy of it in the context of our main care program?
Sure. So we start at the top. The last forecast we ran, we were within 1.5% state general fund dollars in terms of projection. The actuals were. When you look at overall spending, we were, I believe it was 0.8%. So I've used, if you look at the third bullet under Holt-Winter's triple exponential smoothing, that 1.5% of overall main care spending, those are general fund dollars. It's actually a little bit better when you look at the overall all funds number. When you think about how we do in the broader context, I have our team working on a larger document right now. It's a draft form. It'll be finalized soon. Today wouldn't be the place to share it, but I'm happy to share that with committee members soon. But what I've asked them to take a look at is, okay, you know, we think we're doing quite well with this forecast, but how do we compare across the board? Forecasts are used throughout the world. So I've asked them to take a look, Wall Street earnings guidance, for example. You have major corporations guide their earnings. Yesterday, for example, Morgan Stanley missed on its earnings. What they've done is offered guidance initially. They missed the earnings ultimately, so their forecast was off. On the other side of the coin, you have financial analysts on Wall Street who actually work for the investment banks with their own estimates of earnings for various corporations. Early results from our studies there, you have a number of the consulting firms, the large consulting firms, KPMG, for example, study this and see how those private sector firms do. We stack up quite well. That'll be in your document. Another thing I asked our team to look at was commodities forecasting. Commodities forecasting is interesting because you've got a lot of large public sector entities doing that, so there may be more of a comp for us. The IMF and the World Bank, for example, both do broad commodities forecasts, any number of, whether it's copper, lead, oil futures right now. I was talking to some staff members today about why these forecasts matter so much in relation to what we're doing. And you think about oil's futures forecasts, there are a lot of people who've lost a lot of money the past couple of months when you think about the precipitous fall in the price of oil, and that's because a lot of people got their futures predictions and their forecasts wrong. So what I've asked our team to do is look at how we stack up. We've measured ourselves against the World Bank, the IMF, and again, the results look quite good. That draft is in final form right now. We'll share it with the commissioner, and once we finalize it, I'm more than happy to share that with committee members and talk more about it.
So, thank you. But again, projecting healthcare spending is an important but elusive goal, I guess I would say. And what I'd really be interested in, again, how this model's been used in other healthcare programs, in particular Medicaid programs, but also in commercial health insurance programs. I think would be interesting and helpful for us to understand.
Sure, taking into account the Holt-Winter's method, we'll be happy to do that.
Thank you.
And Senator Valentino.
Thank you very much, Mr. Chair. I'm just curious on the Holt-Winter's forecasting that you're using. Is that a program that you have in-house, or is that the service we pay for? Because I know on the revenue forecasting side, I believe it's like $400,000 a year we pay to have the services to forecast on our revenues, plus we have in-house doing. So is this a program that in 2012 you started subscribing to this service? And if you did, what is the cost usually for this? Because I know it's significant for our revenue forecasting, and just wondering what it is for this, or is it just a computer program in-house?
I may have to defer a little bit on the actual funding for it in terms of whether or not we're spending. We use broad-based data analysis. I think we probably pay for that. Most of the forecast after that, or all of it, is interpreted by department staff and analyzed from there.
We can go back and get that specific information.
Just as a follow-up, I was just more curious if it was a service that you subscribe to, like we do for revenue forecasting.
Yeah, the Holt-Winter's model itself is a national model, so whether we have to pay an annual stipend or the such, we'll have to go back. I'm not sure of that answer, but we can get that information for you.
would turn now to the budget initiatives summary. Now, I wasn't sure how much detail you wanted to go into. This is a little different than the press packet that was provided when the budget was announced at the press conference. We included the press packet that was also provided. This is providing more detail, although we're not going through at this time a line by line of all of the budget initiatives. So if it makes sense, we'll just start from the top and work through each of these initiatives. This was intended to capture the vast majority of the budget initiatives in our biennial budget submission.
Just reminding the committee that, this is the overview, and yes, we will have a public hearing, and yes, we will get into it in great detail. Okay, so keep in mind, overview, all right? Thanks.
Yes?
Good.
So at the top of the page, when I mentioned the historical challenges that the Medicaid program has had related to the structural gap, you'll see here, based upon our forecast that Alec just detailed, what we are forecasting for a need, if you will, in each of those years. So $7.8 million in state fiscal year 16,